The Recovery Audit Contractor, or RAC program, uses private contractors to audit Medicare hospital billing records for accuracy. RACs are paid a commission for each claim they deny.
The rules are that a RAC can make a record request every 45 days. And the number of records that they can request varies depending on the size and activity level of the hospital. For my hospital, it's just under 400 records every 45 days. So every 45 days, they throw in the fishing net and they haul out just under 400 records. They sift through those records with a very, very cursory review that doesn't involve a physician expert, I would add. And then they make a determination on the basis of really limited data that that case should not have been coded as an inpatient, and therefore the hospital had been technically overpaid by CMS and should make a payment back.
We're not taking the position that we don't believe we should be audited. We're fine with that. Every industry is audited. That's a completely fair practice. But we don't understand a lot of what's being requested. It doesn't make sense to us. We had a patient that was a chemotherapy patient, and she had required, I'm not a physician, I'm not a clinician, but it required an inpatient admission in order to give her chemotherapy because of some comorbidities that she had. And the RAC pulled all 8 admissions. 4, and over different periods of time. 4 were immediately approved, no finding, and 4 were denied. In intermittent different dates. It wasn't as if a segment of the stay or the events seemed problematic and others. Same condition, same patient, same treatment, 4 approved, 4 denied. So we are, of course, appealing those, and we'll go all the way through to the ALJ level if we have to and expect to be completely successful.
It takes us on average 2.9 years to fully adjudicate an appeal, and we have costs approaching almost $1 million in excess operational costs in order to manage this system.
This really has nothing to do with fraud and abuse. It has to do with medical judgments real time and second guessing after the fact by non-physicians.
Again, we're not above being questioned and audited, but we feel, especially with the focus of the RACs being on whether or not the admission is appropriate, and so they're really just trying to take away Part A versus Part B payment, it's becoming a bit arbitrary in the approach.
Because of our geographic footprint, we have dealt with in excess of 20,000 RAC reviews. We deal with 3 different RAC auditors. So we have quite a bit of experience dealing with RACs as well as all the denial issues. It's a serious issue because for these smaller hospitals, there's an enormous amount of their cash flow that is tied up while they're going through this process. And these are fragile hospitals, typically don't have big foundations behind them, are typically community supported. And it's a serious issue to have their cash flow tied up for that length of time.
It's just a broken system. It needs to be fixed. It can be fixed by simply creating some transparency, some performance expectations, and some alignment of decision-making with the RACs.